All right, guys, we have Dr. Natekar today. He's from originally from Canada, did his medical school in Hawaii, and then now is in Columbus, Ohio. He has a very, very inspiring story, lots of cool stuff happening, and I'll let him introduce himself.
Yeah, so hi guys, my name is Aniket Natekar. I'm a neurologist and a headache specialist, board certified in both. I practice in Columbus, Ohio. I was raised in Toronto, Canada, went to undergrad at Western University in London, Ontario. I did a degree in pharmacology and then did my master's at the University of Toronto in pharmacology as well, with a specialization in clinical toxicology.
Wow.
And then moved on to doing University of Hawaii for medical school for 4 years, graduated 2016, then went to Thomas Jefferson University, where I did my general neurology residency and then headache medicine fellowship, graduated in 2021, and then I moved to Columbus and I've been part of a big system here. And I've been practicing for 4 years now.
Wow. Wow. So much traveling in all between all of that practice. Wow.
Yes.
Let's kind of dive into it. You were telling me how, you had a problem with the visas and stuff. I mean, you're from Canada, but you did school in America. Like,
Mhm.
kind of explain whole that situation, how that was.
Yeah, sure. So, when I was applying, when I got into University of Hawaii, I should
Yeah,
say, I had to be on something called an F1 student visa.
sure.
So the F1 student visa allows anyone international or who's not a permanent resident or citizen in the US to be able to study in the US. And that was typically initiated by the university itself. So I did that. That was for the 4 years. When you're doing your F1, you can take a year to do something called OPT. That stands for optional practical training.
Okay.
So if you're on F1, as a student, and let's say you want to do a year of research, you can then do the OPT program where you can get paid for a year and work for a full year with full employment. You can get a social security number in that time, build a bit of a credit, but it's a good way to get some experience. So a
Sure.
lot of international medical grads or international students will
Mm,
come in. They do that OPT program, get a year of research under their belt while they're in medical school, and then graduate and apply and obviously get into residency. So
okay.
I was on the F1. I was fortunate to go to a school that sponsored H-1B for a work visa. It's a 6-year work visa that's issued by the United States government, obviously. But
Mhm.
in order for me to get it, what we did was my OPT was actually my intern year.
Oh, wow.
So I did my OPT as my intern year so that I could work as a paid employer. And then we sponsored my H-1B starting from second year onwards.
Uh-huh.
So I used 4 out of the 6 years of the H-1B in my last 3 years of residency and 1 year of fellowship. And then I used 2 years of it in the first 2 years of me being employed. And then it's been renewed since.
Wow. Okay.
So yeah, when you're applying for residency as an international
Yeah.
student of any kind, you have two types. You have J1 and H1B. The H1B is the work visa that they give to everyone in any industry. So, you have no problems there. The only restriction really is that it's very expensive and
Uh-huh.
it's more time consuming to sponsor. So, not as many organizations want to do it. The J1 is much easier for them. It's very easy. That one is very limiting in terms of future possibilities right off the bat.
Hmm.
Because what it is sure, if you get a J1 visa, you can do a residency program wherever they sponsor it. But you would first have to go to your home country and cross the border to activate that visa. So you would
Mm,
have to enter the United States through customs in order to do it. And then after the duration of your training, so whether that be residency alone or residency and fellowship, you then either return to your home country for 2 years
hmm.
and then you can come back and practice anywhere in the US, or for 3 years, you have to practice in an underserved area to satisfy the J1 visa requirement. And then after those 3 years, you are then eligible to qualify for H1B or apply for green card, which is permanent residency in the US, right? Or work anywhere you like on any other type of visa. It's very hard to be able to switch from J1 to H1B.
Yeah.
Very few programs do that. And, in very rare cases, you might be able to get a waiver
Hmm.
from the J1, meaning you don't have to be in an underserved area for 3 years.
Sure.
But those are very hard and very far and few between to get.
Okay.
So, those are the basic struggles or descriptions of the visas that are
Yeah.
available for
That,
medical.
that's pretty like it's pretty complex of a system because I know some family members that have to get like J1s to get in, and there's only a few places that actually give J1s and stuff. It's like really hard for them. So when you were applying to residency, did you have like a little trouble looking for spots, or did you kind of just end up like how'd you pick where you wanted to go? Kind of.
Well, so first and foremost, I could only apply to institutions that sponsored any type of visa,
Okay.
whether it be J1 or H1B. I wasn't going to be picky.
Uh-huh.
In my case, I'm one of those people where I'll take whatever interviews I get and
Sure.
then go, and I ranked it based on how I felt I would fit in that program. I
Gotcha.
didn't necessarily rank it based on what visas were offered, whether it be H1B or J1,
Hmm.
because I wanted the best quality education that I felt I could get
Yeah.
for the time that I was going to be there, and I wanted to be able to get along with my colleagues when I was there.
Hmm.
Right? And so I focused more on that as opposed to which visa I would be able to get.
Gotcha.
So I don't know if that answers your question.
Yeah, no, no, that does. That does. Thank you. A little bit more about how you've traveled across borders. I mean, you grew up in Canada, right? Okay, and then you spent your training time in the US.
Yes.
What's the difference in the Canadian side of healthcare and the American side? What in like a summary, what do you think is the main difference, and which one, in your opinion, is better served for patients?
That's a great question. So, a quick summary of the Canadian healthcare system, it is a universal healthcare model.
Yeah.
So what that means is the federal government issues a certain amount of dollars
Hmm.
that are designated for healthcare, and each province will then control how it wants to spend that money. And each province can determine whether they want to implement somewhat of a private system or a public system fully.
Okay.
So Alberta, for example, is one of the 10 provinces, has a two-tier system where they do both private and public.
Oh, wow.
But the other provinces are only public healthcare.
Interesting.
Obviously, that funding comes through tax dollars. So yes, you do pay a little bit more in taxes, but at the end of the day, doctor's visits are all free, hospital visits are all free, ER visits are free, ambulances are free, and medications are heavily subsidized.
Okay.
So medications are a fraction of the cost that they would be in the United States because the federal government is the one who negotiates prices with pharmaceutical companies. And
Interesting.
if a pharmaceutical company refuses to play ball, well, then that drug is not available.
Hmm.
So you do have that. Within the Canadian healthcare system, if you're extremely sick or if you're extremely healthy, the system works really well for you because if you don't need access to care, then you don't really care about how often you need to go
Yeah.
see a doctor.
Yeah.
If you're really sick and you need to see frequent doctor visits,
Yeah.
you can get in very quickly. They'll treat you very quickly. You get everything you need. If
Interesting.
you're somewhere in the middle,
Yeah.
where you're not necessarily very sick, but you're obviously not healthy, let's say, for example, you have a small hairline fracture.
Hmm.
It may need an operation, but it's not something that's emergent right away, and it's not going to impair your quality of life while you're there. It obviously is painful, that it does hurt, but it's not going to prevent you from walking or doing daily chores. Then you might be forced to wait a few months before you can go get your surgery.
Okay. Okay.
Contrast that with the US, which is obviously a private healthcare system. However, there are some aspects in the United States that are a form of universal healthcare. So I don't know if you knew this or not, but the only place that guarantees all types of healthcare to every eligible person in the United States is the United States prison system.
Really?
So if you happen to be an inmate of any kind, you get access to all healthcare and it's all covered. So that's including dental and vision.
Hmm.
Now, could you say that that's an appropriate situation? It's hard to say that because yes, everyone deserves healthcare, but at the same time, they're in an unfortunate circumstance,
Mm-hmm.
right, being in the federal prison system. So it's
Yeah.
not necessarily the best place for them.
Mm-hmm.
Then you have, Veterans Affairs. So if you happen to be a veteran or your family is a member, immediate family, I should say, of a veteran, you qualify for veterans healthcare. Also, if you're active duty military, you qualify for healthcare. Then you also have Medicare and Medicaid. So
Mm-hmm.
Medicare is for designated individuals, typically American citizens 65 and above. You're given a certain amount every year to live on,
Okay.
which is your social security income.
Mm-hmm.
And then Medicare will help supplement a lot of your healthcare costs. So it'll cover a lot of the doctor's visits or, hospital stays, ambulance, and it'll subsidize medication costs.
Sure.
So if you've seen recently, insulin, for example, is no longer more than $30 for
Yeah.
anyone who's on Medicare. A Pixaban, which is known as Eliquis, which is a very potent blood thinner that is extremely useful. Previously was several $100s, now it's down to like $200
Hmm.
a month because Medicare negotiated the costs of it.
Hmm.
Then you have Medicaid, which is state funding specific to provide healthcare for those who are in lower income or have no income situations. And so these are the different types of universal healthcare that exist within a for-profit healthcare system.
Gotcha.
Everyone else is commercial insurance, so it's tied to your employer for the most part. So
Hmm.
if you're employed, your employer will typically provide you with health insurance, or you purchase your own plan. You have two big types, which is low deductible or high deductible. And a deductible means the amount of money that you pay before you satisfy the requirements, and then everything else after that will be covered. So if
Hmm.
you have a high deductible, that means you owe up to that amount. And then once that amount is hit, the insurance company will start paying for stuff.
Hmm.
Versus a low deductible, it's much easier on some people, especially if you have chronic health conditions. A low deductible might be more appropriate. Within this, if you're unemployed, then it's very hard sometimes to purchase your own plan.
Hmm.
So a lot of healthcare is tied to employment. And even if it's tied to employment, not all employers offer the most comprehensive healthcare because obviously they want to save money. They're for-profit companies too. So they'll cover the bare minimum.
Interesting. Okay.
And so you have that option. The other option that's also out there is you just pay for the care yourself if you don't want to pay for health insurance.
Hmm.
And not many people can afford that, but some can and some choose to.
Got it.
Within the US model, if you have health insurance, you're pretty much going to get guaranteed to be able to see a doctor or nurse practitioner, physician assistant. The wait times can be long depending on the specialists that you're seeing. Some can take 1 month, some can take 6 months. For example, for me, I book out up to 6 months in advance.
Mhm.
Then, obviously the difference is there's a copay typically when you see me. So what that means is if you were to see a specialist or even a primary care physician of any kind, there would be a payment that you have to give after the visit is done.
Mhm.
And then you may receive a bill for labs that were done, and obviously medications are going to be more expensive in the US than they would be in other countries.
Mhm.
So you'll have to pay for all of those things. And then, people talk about, well, if you have money, then yes, you get access to very good care. And what I do find is a lot of the care is expedited in the US versus other countries, including Canada, because there's more resources.
Mhm.
There are way more MRI machines in the United States than other countries. So you can get an MRI much quicker. So all of these things you do find work better in the US than in most other countries.
Interesting.
What I will say though is the United States outspends every other country by far.
Mhm.
So it's about $1.7 trillion, I believe. It's about 30 to 40% of the total GDP or that could be less, sorry, I could be quoting that number wrong. But a significant amount of the GDP is spent on healthcare. But you look at overall outcomes, the United States isn't anywhere close to the top. So whether that be life expectancy, infant mortality, maternal mortality, the number of chronic health conditions that are in the US versus other countries is significantly higher. The rates of all of these terminal diseases or cancers are also significantly higher in the US than in other countries. So despite the vast amounts of healthcare spending, the quality of care is hopefully there, but you're not seeing the outcomes that you would expect for such money that's being spent.
Gotcha.
Canada is spending a fraction of that cost. Now, sure, you
Hmm.
might have to wait a while, you don't have as much access to a specialist, but you do find that the metrics are better in Canada for a lot of these things,
Yeah.
as well as in England, Australia, and every other major country. So when you think about it from that perspective, I find universal healthcare to be a little more appropriate because I don't know if you knew this or not, but 2/3 of GoFundMe pages these
Mhm.
days are for healthcare related costs.
Wow.
And I think it's something like 60% of all bankruptcies in the United States are related to healthcare.
Yeah.
So, these other countries, while you may not get a doctor as quickly as you would in the US, there's a much less chance that you'll go bankrupt.
Interesting.
Which just means that it's a little bit better. And its studies have shown if the US was to switch to a universal healthcare model, the quality of care would still be there, the US would save approximately, I think it's like a few $100 million a year. And the average American family would save like 800 to $1,000 a year in healthcare premiums. So,
Interesting.
everybody would save money.
Yeah. So I have a question on that. So you're saying if we were to do universal healthcare, the outcomes can be better according to statistics. But do you have a way, do you have some thought on how you can get the fast pace we have already in the US while having that universal aspect? Is there a way that can be done, you think?
Yeah, so one of the things that we talk about is that there's a significant doctor shortage.
Yeah.
So the United States is uniquely positioned where the topics of physician assistant, or I believe the new title is physician associate, as well as nurse practitioners. The United States is the only country that actually has these programs.
Mm,
Canada has just started a nurse practitioner and physician assistant program. I think England is starting to incorporate them, but several other countries still only have physicians. But you
sure.
have a significant physician shortage. Okay,
Yeah.
well, there is a large immigrant population in the United States who were doctors in their home countries before they came here.
Hmm.
And unfortunately, they're forced to redo residency in the United States in order to practice a particular field.
Yeah.
So, I've met some who are family doctors, but it turns out in their home countries, they were orthopedic surgeons. There was one guy I met, he's a family doc here, but he was a cardiothoracic surgeon in his home country.
Hmm.
These are skills that we could benefit from. So,
Yeah.
one thing that maybe we could try to do is a year of supervised practice. So they work with a board certified American physician or an American board certified physician in the United States for a year. And if that physician signs off saying, yes, they're competent to practice, they do a great job. If these guys pass the American board exams for that specific specialty and they've met the work requirements, that might be one way to help. Another thing that the United States can do is, unfortunately, I had to say it this way, but if they could waive the difficulty for physicians to get permanent residency in the United States, make it easier for us, I should say,
Yeah. Yeah.
to get a pathway towards permanent residency,
Sure.
then, that's one more incentive for more doctors to want to stay
Hmm.
in the United States. And when you do it that way, I think you would be able to address the universal healthcare system. The other thing is also with universal healthcare, the goal is you don't close hospitals. So what happens uniquely in the United States is also a lot of hospitals close because they run out of money.
Yeah.
Whereas with universal healthcare systems, they fund their hospitals. There
Yeah.
are no private hospitals.
Hmm.
So as a result of it, if a hospital is struggling, they will then try to go in and fix the issues versus in the US, they'll close them. I believe in the state of Mississippi, they closed 18 hospitals last year. Right? And so now whatever hospitals remain are going to be overburdened.
Yeah.
And then if there are doctors who used to practice in those 18 hospitals, it's not like they're guaranteed jobs in these hospitals that are left to
Hmm.
help ease that burden. So that might be something that they could look into.
Hmm.
Right? And with the overall cost savings with universal healthcare, you could then spend that money on increasing class sizes, increasing residency program sizes to
Hmm.
help fund the influx of doctors that are needed.
Yeah. Okay. Wow. Never thought of it like that. Thank you for that. That was pretty
Yeah, of
insightful.
course.
Yeah. Switching gears a little bit, tell me about residency, how you came to choose neurology, and why you chose to do a fellowship after that.
Yeah, no, great question. So from my end, when I first started medical school, I was thinking of doing family med actually.
Oh, wow.
So like, yeah, completely different field.
Uh-huh.
But what I learned very quickly was that, while I enjoyed some aspects of primary care, I
Mm,
didn't necessarily enjoy the pediatric or the OB-GYN as much as other people would, for whatever reason.
uh-huh.
I guess for me, I like being able to get answers from people when I ask a question. And obviously children, I have a harder time with that. And if you're relying on parents, it may not be as accurate.
Yeah.
And then I did OB-GYN and surgery as my first two rotations back to back. And I learned very quickly I'm not meant for the OR. So that helped. And then when I was there in medical school, step one was not a pass fail. It was
Yeah.
actually still with the mark. So when I did medical school, my mark eliminated some of the more competitive specialties
Oh, okay.
like dermatology, plastic surgery,
Gotcha.
things of that nature. So, I knew right off the bat it's more going to be limited to internal med or along one of those kinds of fields. And
Mm.
when I was studying neurology, I really loved it. I loved the puzzle.
Uh-huh.
of trying to determine where's the lesion or localizing the lesion, as neurologists like to joke about,
Uh-huh.
based on someone's symptoms. And every time we had a neurology patient in medical school, I had more of an interest in it. I found that I was gravitating towards those fields. And then I did 3 OA rotations. So I did one at UCLA, one at University of Toronto, and one at Mount Sinai, New York. And when I did all three, that solidified it for me that I was going to apply for neurology. It was the perfect field for me, I at least feel. One thing that I enjoyed in residency was the art of medicine. I find is still there in neurology compared to a lot of other fields.
Mm-hmm.
Obviously, this is just my opinion. Others may have their own,
Mm-hmm.
but I find that in some other specialties, you're more reliant on labs or imaging or both. Versus with neurology, it's based on your symptoms.
Yeah.
Do we need to get an image or not? And if so, which image and where and why are we doing it? Or an EMG or certain lab tests,
Mm-hmm.
things like that. I find that the art of medicine was still there in neurology. So
Yeah.
those are the main aspects. And also there's a lot of aspects of primary care within neurology. Proper diet, exercise, hydration, all of these things that are important in primary care are just as important in neurology, because if you want to talk about stroke prevention, you want to talk about Alzheimer's disease progression, you want to try to slow it down, healthy diet, exercise, hydration are all keys. Parkinson's disease studies have shown exercise has helps, right?
Yeah.
So that's what I mean by there are still those aspects. I'll happily start someone on a statin if they have high cholesterol because I want to prevent stroke, or I'll start a blood pressure med to try to prevent stroke.
Mm-hmm.
So, I'm not afraid to do these things because neurology helps you train for all of those things.
Mm-hmm.
Then I chose headache as the fellowship because I found that headache medicine was the most underrepresented in terms of research dollars given to the programs for funding, fellowships, for the total number of patients who have the said disease. What I mean by that is, for example, something like MS. There's approximately 2 million Americans who have MS at the moment.
Yeah.
Significant amount, obviously a very debilitating disease, deserves a lot of attention. I don't want to take anything away from that.
Mm-hmm.
Right? But when you think migraine and other headache disorders, several million more people, 13 to 15 million people in the US suffer from some sort of headache disorder.
Yeah.
But you don't really hear about the funding for it as much or as much advocacy for it. And I found that, compared to a lot of other people, I'm able to communicate my message a little bit better. So I wanted to lend a voice to this kind of a field that I felt was underrepresented in terms of advocacy and research dollars. In addition to that, you get to see people from all age groups, so you're not isolated to just one age group.
Mm-hmm.
And if you do get someone better, it's not typically a terminal disease. That's the headache disorder. And if they are better, you can see a significant improvement. You'll see people happier, quality of life, and you'll know that you've had a positive impact.
Mm-hmm.
Right? Now, not to say you can't have a positive impact in all the other subspecialties within neurology. Absolutely. But for me, within headache, I found that was gratifying.
Interesting. That's how you got to it. How are you liking it now? You enjoying it?
Yeah, so what I do is I do 50% of each. So I do 50% general, 50% headache. So, within the general side, I'll see stroke patients, seizure patients, cognitive impairment patients, weakness, neuropathy, the more of the bread and butter stuff. And then within headache, I like what I do. Could I do headache only? I don't know, at least not yet. And the reason why I say that is because I also did a 4-year residency. I don't want to lose those skills in addition to, right? Like, for example, I just picked up cervical dystonia with Botox.
Wow.
Because I do Botox for migraine anyways. So then I had several colleagues just teach me how to do it. And now I've been doing it for hemifacial spasm. So if they're having issues with a spasming of half their face, or if they have cervical dystonia, I'm able to do Botox for that too. Now, if I stuck to only headache, I wouldn't see those patients.
Yeah.
There's a severe lack of general neurologists these days. Because a lot of us become subspecialized, and a lot of institutions want subspecialists so that they can advertise, hey, we have an MS center, we have an ALS center, or whatever. And so by me sticking to general neurology, I help satisfy some of that need.
Got it. Wow. Thank you for that.
Yeah, of course.
I think Dr. Natekar, That's a broad array of information. I think that was great stuff, good insights. I hope the audience finds that very like inspiring, informative. I know I learned a lot, especially on the healthcare side. That was pretty good. So thank you.
Yeah, I hope so.
Yeah. Thank you for taking the time to do this.
Yeah, of course. Of course. It was a pleasure.
Yeah, yeah. Well, thank you for coming on, and we're happy to have you.
Yeah. Time.